Well, thanks so much for joining me today for episode 9 of season 2 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. I want to again begin today by thanking and acknowledging the SCAN group for which I work and the closely affiliated SCAN Health Plan for supporting and sponsoring this podcast. For those of you not familiar with SCAN Health Plan, it is one of the largest nonprofit Medicare Advantage plans in the nation, and they truly have a great nationwide reputation for the great work they do caring for frail older adults. I'm very proud to be affiliated with the organization. I will say that the views I express in this podcast are my own and don't reflect those of SCAN as an organization. So the topic we're going to cover in today's episode is very relevant to the work that SCAN does for frail older adults. My guest is Dr. Elena Hill. She is a family practice physician with the Bronxcare Health System in the Bronx, New York. And she wrote a piece recently in a family medicine journal titled Slow Medicine. And really love the article. It caught my attention because it contrasts so much with what we do so often here in the U.S. healthcare system with aggressive, high-tech, invasive interventions that don't always align with patients' goals and values. That's what I would probably describe as fast medicine. And this comes often at the exclusion of simple, slow medicine approaches that would, in many cases, be much better. I actually used to write a blog with my good friend and colleague, Dr. Peter Cohen, titled Updates in Slow Medicine. So this is very much rooted in the Healthy Skeptic MD and my own personal philosophy here. And I also just want to give a shout out to SCAN, because one of the reasons that I am at the organization is because it does such a good job of balancing slow medicine approaches like Elena is going to talk about today with when it's appropriate to do more aggressive fast medicine interventions. So it's a great episode. Please do stick around for it. If you do find today's episode engaging, please search and subscribe to the Healthy Skeptic MD wherever it is you listen to podcasts. Search for us on YouTube, Healthy Skeptic MD, and subscribe to the YouTube channel. Pass it along to friends, family, and others who might be interested. And if you do have a moment, please do leave a review. That's very much appreciated. Okay, so before we jump into our interview with Elena today, as always, let's do a quick rundown of the health news of the week. And I'm actually going to skip COVID-19 this week, if for no other reason than my own personal sanity. I know we're all being bombarded all the time with COVID-19 health news, but this week there were a couple really important non-COVID studies that I thought were worthy of attention. So the first has to do with pre-exposure prophylaxis for HIV. So many of you may be aware that a couple years ago, a daily pill became available that really significantly reduces the risk of HIV infections among those at high risk, for example, due to high-risk sexual activity or IV drug use. Now, the big problem with this intervention, this medication, is that you have to remember to take it every day. And if you don't take it every day, it becomes much less effective. So this analysis found that an injectable version of the medication that's given only once every 8 weeks was much more effective, in fact, more than 50% greater efficacy than the daily pill version for preventing HIV infection. So this is great news for HIV prevention, but it's also relevant to other conditions like schizophrenia and substance use, where remembering to take a daily medication for various reasons is hard. And there are technologies for long-acting injectable versions of schizophrenia medications and substance use. We talked about that a couple episodes ago with Dr. Stephen Hochman, my brother, with homeless healthcare. So I think this is just a really nice demonstration of the value of these long-acting injectable medications, and hopefully there'll be more on this to come in the years ahead. Okay, so the second news item I want to touch on is actually very relevant to our discussion of slow medicine that's coming up, and it's about the use of a procedure called a revascularization procedure for treating patients who have blockages in the arteries feeding blood to the leg, and that can trigger leg pain. Now, these are very invasive, aggressive procedures. They're often done in frail older adults, and they're also very lucrative to the healthcare system. They're reimbursed very generously. And over the last several years, there's been a 31% increase in the use of these procedures. And one of the concerns is that there are financial incentives that are driving these decisions, and maybe they're not always in the best interest of the patient. So in a new analysis in JAMA Internal Medicine, they found that more than half of patients after having one of these procedures, died within 2.7 years. In other words, we're doing a lot of these procedures in patients towards the very end of their life. And there was an editorial by Dr. Rita Redberg, who was also a previous guest on The Healthy Skeptic. She talked about the use of daily statins, one of the more popular episodes, so check that one out. And she just said, we really need to think twice about doing these procedures in frail older adults, and that many of the simple, slow medicine approaches like lifestyle changes, eating healthier, exercising, quitting smoking are probably much better options for these adults. So if you have a family member, a friend who's being recommended to have one of these revascularization procedures, you really want to sit down and think, are there other less invasive alternatives? And does this aggressive procedure really align with that person's goals of care? So that's it for the Health News Summary of the Week. Let's jump into our interview with Dr. Elena Hill. Well, welcome to the Healthy Skeptic MD, Dr. Elena Hill.
Thank you so much for having me.
Well, really happy to be joined by you today. So you just last year completed your residency training, your medical training at one of those fancy Boston hospitals, Boston Medical Center, where I also went to a similar one. And what was your experience like doing your residency training at Boston Medical Center?
So I loved my training. I'll start by saying that in family medicine in Boston, family medicine is a smaller specialty on the East Coast as compared to other parts of the country. So I felt really privileged to train at a place that really valued family medicine and primary care in a city and in a state that there's a lot of specialty care. And so we were sort of the minority in the area, but I felt like I got first-rate training. And I think we got all of the advantages of working with sort of underserved, marginalized populations of Boston with all the resources of a big academic medical center. So I was learning from really just brilliant mentors and felt very lucky in that respect. But I think that one of the things that I started realizing over the course of residency was that because we had so much access to all of these tests and specialists and high cost treatments, there's a lot of pressure to use them because we want to make patients better, right? But and it comes from a wonderful place of wanting to help. But at the same time, I felt like I was doing a lot of stuff all the time for patients and not really feeling like those patients were necessarily getting better. And I could see their frustrations that they weren't getting better. And so I think, Boston is an excellent place to train. I loved my training. It really prepared me for the community setting I'm in now. But I was starting to really doubt that aspect of how we train doctors and how I was getting trained. And so I really enjoyed now being in the community setting.
And that's actually the next question I wanted to ask you. So after training in a very high-tech academic medical center environment, you made a somewhat unusual decision to work at a community health center in the Bronx, taking care of underserved populations. You probably could have made more money working somewhere else. How did you decide to take that job?
And I think it's kind of a sad thing that we still live in a world where it is an unusual decision that you see somebody that goes from academic medicine to the community setting. There should be a lot more of us. And I think one of the things that really solidified for me, I think that so many young doctors, and we know this, right? We look at the literature and we see that so many doctors go into medical school because they really, truly do want to help people. They want to help make people healthier. And the research really shows that somewhere around intern year, I think pretty consistently of residency, that interest starts to drop off and people go into more specialized fields. And so I think that there is a real drop off of people going into community medicine because you're right, there are more lucrative opportunities, more other opportunities in more academic centers. One of the things I actually did was the National Health Service Corps. And so for those that are not familiar, the National Health Service Corps is a federal program that helps to sponsor medical students and residents to go into underserved medicine. So it's essentially a loan repayment program or a scholarship program, depending on exactly what program you choose. But they help you pay for medical school, and in exchange, you get to work for them in any number of underserved settings. Those can be urban, those can be more very rural settings. And so that sort of commitment really helped me to stay on track with what I knew I wanted to do going into medical school.
Yeah, I think National Health Service Corps is a great program. I sort of think of it as like Teach for America for doctors. And it really does get very committed, some of the top performing medical students and residents to finish and then go work in an underserved community and at least give them that exposure and that opportunity. So really great that you're an example of someone who took advantage of that and is benefiting the community. Now, Elena, you're working in the Bronx and you also have an expertise or specialization in chronic pain and addiction medicine. That's also not the most common interest. How did you become interested in that topic?
Chronic pain patients, I think chronic pain has a lot to do with slow medicine, which we'll sort of talk about what slow medicine means. But chronic pain, 90%, I would guess, right, of doctors, don't quote me on that statistic, but, most medical visits are about pain in some capacity. That's why most people go to the doctor, is they have a physical ailment or a complaint. And chronic pain is a very nebulous field in which we oftentimes don't know what's going on. And it's very hard to treat. We have very limited pharmacological options for patients, and there's a lot of frustration. And so it's a disease that really lends itself to slow medicine and to slow care and to working with patients over time. And so I think it's a population that a lot of physicians sort of dread seeing. And they like to ignore because we don't have the answers, right? And it's a lot easier for us to say, well, this person's whining and there's nothing wrong. And so it's a population that is really largely ignored. And so I think that it's a population that needs a little bit more of our attention and needs a very slow approach to care. And so that's why I sort of fell in love with it as a population. In addition, a lot of these patients have been thrown on opioid medications, which is a very hot topic in the world of medicine right now. And so we're working with a lot of these patients to reassess their need for opioids, which we know can sort of exacerbate chronic pain over time. And so it's become a real clinical interest. And I think I utilize slow medicine when I work with these patients as much as possible.
That's great. I have to say, I was one of those doctors when I first finished my training where I was not excited about the patients with chronic pain because I felt helpless. I felt they always wanted something, a prescription for me that I wasn't able or comfortable necessarily giving. And I think you're exactly right that the slow medicine approach, rather than throwing medications at the problem, is so often the answer. So, really appreciate that important work that you're doing. And so you mentioned the term slow medicine, and I came across your name because you wrote a really beautiful article, a perspective piece in a family medicine journal titled Slow Medicine. And actually the precursor of this Healthy Skeptic MD podcast was a blog that I did with my colleague, Dr. Peter Cohen, called Updates in Slow Medicine. And at that time, there were very few people using the term. So tell us, begin with some definitions. What is fast medicine and what do you mean by slow medicine?
Yeah, and it's a difficult thing to define. I think that fast medicine, and it's becoming, like you said, a much more common term. I think that fast medicine, in my mind, is the kind of medicine that we have been taught to practice in the United States. It's the idea that, because we are unique, or not unique, I mean, other countries have fantastic medicine, but we are one of the most resourced countries when it comes to the medicines we have and the technology we have to treat disease. And so we're really trained in this fast medicine environment where we have pills, we have procedures, labs, imaging studies, all of which we think can solve the problem quickly and efficiently. And at the same time, we're a country of slow diseases, right? What are the things that kill people in this country? People die of heart disease, which is something that develops over time. People are dying of chronic conditions like cancer, like hypertension, like diabetes. All of these diseases require extensive education. They require monitoring over time. They're chronic, non-curable, but treatable diseases. And so we're kind of in this position where we're treating slow diseases with fast medicine, and it's just not working. So fast medicine is sort of the concept of being able to do things, big drastic things quickly and solve big problems. And I think, don't get me wrong, some of the things that my surgical colleagues and specialist colleagues do are just amazing and are totally curative, and I have so much respect for that need in medicine. Slow medicine, in contrast, the way I think of it is it's about stepping back and asking the question, is each intervention, is each thing I do to a patient or for a patient really going to make them better? And when I say better, when I say health, I don't mean, improve their life or their mortality by 30 days. What I mean is, are they actually going to enjoy their life more? Are they actually going to be happier and feel healthier day to day? And if not, then let's not do those things. I like the the expression, and don't just stand there, do something. Slow medicine is really about, don't just do something, sit there. When a patient comes in a concern, we don't have to immediately solve that problem in one office visit. So many problems in medicine are unsolvable, and so a lot of times when patients come to me, they're coming to me for an issue that they've had for years. I don't think they actually expect me to fix that problem in that one visit. What they want is to be heard. What they want is to have reassurance that they have someone that's going to be working with them in the future to control or maintain a problem. And so I think there's a lot more value to that. So slow medicine is about really taking the whole patient into consideration, thinking about all the advice from the different specialists that they're seeing, and then synthesizing it into a plan that actually makes sense for them and that they're excited about and that they buy into.
Well, I think that was so well said. The only thing I might add to that is that sometimes slow medicine is the treatment that solves the problem. So many times people will come in with an ache or a pain, or they're tired or anxious, and listening to them, reassuring them, and giving the body time to heal. That's actually the treatment, is to just provide the reassurance.
Right. I mean, what did we do for thousands of years before we had these pills and potions? What we did to treat each other was we listened to each other. If someone had an ache, we massaged that ache for our loved ones. We touched each other. We use so many other techniques that doctors are just not doing anymore. We barely do a physical exam these days. So just looking at a patient, putting a hand on their shoulder, doing some sort of physical exam is really helpful in just helping people to truly feel better.
So, Elena, I want to read a passage that I really liked from your recent piece. You write, "Americans love fast medicine, flashy machines, new technologies, and cutting-edge procedures. We get so wrapped up in the million expensive, extensive, and excessive ways that we can treat any condition that we often forget to ask, how much healthcare are we actually helping our patients obtain?" Could you expand on this? I particularly like that ending point, about, is what we're doing actually making patients healthier?
Yeah, and I think I talk a little bit about that in the article itself. I use sort of a carotid endarterectomy as an example of a procedure that is, a very, flashy procedure that can, help prevent stroke. And so I talk about that a little bit in the article. But, is it all right if I give you another patient example I've been thinking of recently?
Yeah, please.
I was recently working in the hospital, taking care of a lovely gentleman who's about 85 years old, with advanced dementia. Very pleasant, but not totally oriented, and didn't really know who we were and who he was, and so pretty advanced dementia. And he came into the hospital, sadly, with what turned out to be a pretty big lung mass, presumably a lung cancer. And so, of course, I did my due diligence as the the hospitalist, the generalist doctor, and I got the specialist doctors involved. He saw the pulmonology team, the lung doctors. He saw the oncology, the cancer doctors. And, in keeping with the next steps for any lung cancer, they said, well, let's get a biopsy of this tumor and let's do a procedure. And then let's talk about what surgery he could do. And maybe he needs radiation and chemotherapy. And I thought, the first thing I thought was, oh, my God, this poor guy doesn't know what's going on right now. He's not scared. He's very much at peace. He's not fearing a cancer because of his, state of dementia. Do I really want to, stick a needle in this guy's chest and get a biopsy? And then, assuming that biopsy shows cancer, am I really going to, subject him to a surgery when he, it doesn't, no, it just felt like so much. It felt like to be doing so much to this person's body. And of course, my colleagues were just doing what they knew to do for any standard lung cancer. And I thought they're completely doing their job. But my job, and I think the job of primary care doctors and why primary care is so important, is to step back and synthesize, take the opinions of different specialists and then look at the picture, look at the patient and the patient's family and say, is this really going to make this fellow healthier? Or is he going to be healthier if he gets to go home and hug his grandchildren and watch them play in the yard? And as soon as his wife came in and we had the discussion about a biopsy, she was very much in agreement. And I think that's the power of slow medicine as a philosophy and the power that primary care doctors have to step back and look at that patient as a whole and then help families decide what they really want out of their care. That's what slow medicine is about to me.
Well, that really reminds me, I worked for a while at the Veterans Administration. I saw a lot of male patients, older men. And I remember one day there was a gentleman who came in and he sort of was looking discouraged. And he said, things have just been all downhill for me since I got that prostate cancer screening. And he had gotten screened and identified as having a cancer, and he'd had surgery and radiation and had some incontinence. And his quality of life was really a lot worse than it had been. And prior to that, he was perfectly healthy, functional, doing things with his family. And it just sort of struck me that, gosh, was this really the right thing to have done to identify this cancer that may never have even presented itself in his lifetime? And it really hit home the point that every test you order, it can be opening up a Pandora's box. And you really need to think, is this the direction that makes sense with this person's goals of care?
Absolutely. Yeah.
So I often think of slow medicine and fast medicine as the yin and yang of medicine. I think you and I would all agree that there are places when we need fast medicine. If someone's having a heart attack, we need to get them into the cath lab as fast as possible, assuming, of course, it aligns with their goals of care. But in American medicine, we seem to be a little more skewed towards fast medicine and not doing enough of the slow medicine things that you talked about. Any idea why and how this came about?
Yeah, I think there's a couple clear etiologies. I think the first comes down to medical education. And I think that the second and third are probably the availability of these services in a way that they aren't available in other places. And I think the third is probably the incentive system that we have in this country to use these medications and the incentives that doctors have to order more things because that's the way we get compensated. Now, I'll give a little example as a recent graduate from residency. I still very, very vividly remember the anxiety and the fearfulness of not doing things just because that's the way they were done, right? So if I'm in the hospital and every single morning I'm ordering a CBC and basic lab work for a patient every single morning in the hospital, whether or not I'm really expecting it to be abnormal or not, I'm ordering it. And when you think about that, that's not a benign thing, right? That means the patient has to get woken up at 5 a.m. when they're trying to sleep and rest and heal themselves to get a blood draw. And then that blood draw, if there's something abnormal, we have to work it up and we can't let them leave until we make sure it's normal. And so that can be very harmful. But as a resident, I didn't at all feel comfortable not ordering that lab, even though I didn't think it was important because I thought my boss, my attending doctor is going to say, why didn't you order morning labs? And so I think our trainees are given the message that they are not empowered to think deliberately and to make decisions based on what they think is really good medicine. So there's that component of it. And then they go into practice and they practice the same way that we've been teaching them. And so now when I work with our residents at my current job, I tell them or I ask them, I say, why are you getting that CBC this morning? And sometimes they even just look at me like I'm crazy. They say, I'm getting it because I have to get morning labs. And I say, who told you had to get morning labs? I didn't tell you that. Why do you want to get this morning lab? And sometimes they say, gee, I don't. It's not going to change anything I do. And it's this beautiful moment where you get to watch them realize that they have the power to make these decisions and help them to really think about why they make all this decisions. I think that's going to make them better trainees and better residents or physicians eventually. The other thing is I think our financial incentives are really perverse in this country a lot of times. I still get pressure from my boss to see a certain number of patients per session because each of those patients is billable. And we need to make sure the department is making money. And so there is that pressure to see a certain number of patients. I still check off the little box that says I ordered labs during this visit, and so I should get paid for those labs that I ordered. And so I am actually incentivized on a daily basis and reminded on a daily basis that I need to spend money and do more stuff and order more labs. And I think that if we worked in a system, potentially a capitated system, where I was getting paid just a certain amount of money to take care of a person, and it didn't matter if I spent an hour taking care of that person or 20 minutes, I would have a lot more autonomy to say, well, this person needs a little bit more of my attention today. Let me give them a little bit more time and do some extra counseling and conversation. And I'd be providing better care. So I think it definitely comes down to the way doctors and the way hospital systems are compensated for the care we give. That's driving the system of fast medicine.
So I completely agree that the medical education piece is a real important contributor and the payment and incentives are. I would actually add two additional factors on that list. One is it is a lot of cases easier to practice fast medicine than it is to do slow medicine. And I remember one of my attending physicians, David Bohr, the chief of medicine at Cambridge Health Alliance, where I did my training, he used to say, ordering a CAT scan for every patient who comes in, that's just intellectual laziness. It's so much easier to just hit the button, have the scan go through, and you'll find what you find and go from there, rather than going over being thoughtful, finding out what the patient's goals of care are, listening, and seeing if there really is a need, and is it going to change your management. The second factor that is often brought up, and I think incorrectly so, but I do think it is a driver, is the malpractice litigation system. And people feel that if they order an extra test, an extra study, they're less likely to end up with a lawsuit. And my anecdotal experience and some of the evidence is that's actually not the case. What patients, when litigation comes out, is when there's a bad relationship between a patient and a doctor. And people who practice slow medicine and have strong bonds, patients are more forgiving if you don't do everything exactly right. And then at a very practical level, every test you order, it's got to be followed up. And the couple of legal cases that I've seen, I've been peer reviewers for and so forth, have been from random labs that no one thought to look at and ended up, not getting followed up. And those led to lawsuits. So my view is that we doctors over worry about the litigation, and we think the answer there is to order more, do more, but I actually think the slow medicine could be a piece of the solution there. I just want to ask you one more follow-up question about the medical education. We recently had on the Healthy Skeptic MD two medical school deans. We had Mark Schuster, who's the dean at Kaiser Permanente School of Medicine here in Southern California, and we had Dr. Pedro Joe Greer, who is the dean at Roseman School in Las Vegas. And they were both so mindful and attuned to these issues of giving doctors in training, the wrong message that always, thinking of the crazy diagnosis or ordering the unexpected test, that's what being a good doctor is about. They're really trying to change it. But I think both really acknowledged how hard a culture it is to change. And since you're so much closer to it than I am, to what extent was your medical school and residency, were the residents who did more and ordered more, were those the ones who got the sort of the highest marks?
I think it is a culture that is changing slowly, and I hope it's reassuring to you and to people that have been in this game longer than I have and have been fighting for this longer than I have, that I do feel that my medical school talked about slow medicine as a concept and was challenging us to think about, what really confers health. And so I think that this is permeating to the level of our trainees slowly but surely over time, because I certainly feel like it was something that I was exposed to as early as medical school and was definitely exposed to in residency as well. And so I'm optimistic that this is going to be part of medical training, and that we're going to see doctors thinking more deliberately about what they're ordering. There's some wonderful campaigns out there. The Choosing Wisely campaign is a great resource that looks deliberately at specific tests and whether or not they're cost effective and at their actually and makes clear recommendations about what should and should not be ordered in various circumstances. So this concept is out there, and I think it is growing, which makes me optimistic.
Well, it is. I do see signs of progress. It's slow. Culture change is always slow. And I also think that managed care incentives, there's a lot of bad things about managed care incentives that, denying patients care that they need. But one good piece of it is that being parsimonious and thoughtful, giving patients what they need, but not more, is actually the best care you can give them. So, hopefully with time, our philosophy and our culture is going to continue to evolve. One other thing in the article that really caught my attention, you said your favorite all-time study is a study that showed that empathy for patients who had a cold was one of the best treatments. Could you tell us a little bit about that study?
Yes, I I love this study. It blew my mind as a medical student. I just thought it was the coolest thing. I believe it came out, I want to say like 2009 in Family Medicine. It was a very simple study. They looked at patients coming into the office visit with a common cold, right? A very routine, not urgent, not a big deal. And one of the things that we kind of roll our eyes at as clinicians, because we're so used to seeing it, we say, oh, no big deal, get over it, you'll feel better in a couple of days. And so it's very easy. It's one of those issues that it's easy for us to not be very empathetic about. But when it's happening to you, I don't know the last time you had a common cold, but I had one last season, and I thought, God, this is really pretty awful, and I should be more empathetic. But this study looked at doctors that were either told to just do what they normally did, or they were told to say specific words that were supposed to demonstrate empathy. So the patient's statements like, oh, I'm so sorry you're feeling this way, I understand, basic things like that. And they randomized them, and they actually found a statistically significant difference in the amount of time it took patients getting better from these self-reporting getting better from these symptoms. It wasn't a huge difference. I think they felt better a day earlier than patients that didn't have that empathy. But it goes to show that if what we really care about is making the patient feel better and be healthier, therefore, just showing empathy, not ordering a single test, not spending a single dollar, but just showing empathy is an intervention that worked. And so I just thought it was it speaks to what slow medicine can do.
Well, when I read that, it went through my mind that if there was a pharmaceutical compound, a medication that had a statistically significant impact on resolution of cold symptoms, we wouldn't hear the end of it from the marketing folks. It'd be advertised all the time on TV. And yet something like this that's so simple is probably not being disseminated and used as widely. And I'll just say, having kids, I've learned this lesson myself. When they come to you with a stubbed toe, if you just say, knock it off, move on, they're going to keep complaining about it. But if you take it very seriously, get them a Band-Aid, act all very sympathetic, it actually has a lot of therapeutic benefits. So something we should all probably take advantage of. So let's go from the individual level to the macro level. In your article, you also mentioned that despite all the fast medicine, expensive care, high-tech care we provide in the United States, health outcomes of Americans are no better, in some cases worse than many other countries. Is part of the explanation here that we're just doing too much fast medicine and not enough slow medicine?
Absolutely. I think so. I mean, I think that if you look at the vast majority of the treatments that we offer, that, the fast medicine that we offer, the pills, the MRIs, the specialists, the interventions, surgeries, the evidence for a lot of them is really pretty weak. In fact, I think patients would be a little bit shocked and scared to know how little evidence we have for a lot of the things that we do. So, I mean, let's take a very simple example of Metformin, which is the first line, very common diabetes medication that we give patients. So there's a big controversy these days about whether or not you should be giving this medicine to people that have what we call pre-diabetes. So they've got a little bit of elevated sugar, not quite diabetic yet. And there's I've been reading a bunch of studies recently. Should we be giving Metformin to these pre-diabetic patients to help prevent them from progressing to diabetes? And the evidence is we really don't know. And so instead of saying to a patient, this is a pill that is going to help prevent diabetes, what I try to say to patients is, we've looked at it and we don't really have an answer. Some doctors might tell you that this medicine will help you help prevent you from moving to developing diabetes. Some doctors might disagree. And so I'd like to talk to you. Are you the kind of person that likes taking pills at all costs to make sure we prevent any, bad outcome? Or are you the kind of person that hates taking pills and doesn't want an extra pill unless we're really sure it's going to definitely be helpful? And I let patients decide. And I think that so many, Metformin is a very simple example of that, but so much of what we do, the vast majority of all the pills that we use are off-label. Right? We don't have FDA approval for what we're using them for. There's so much in medicine we don't know, and it's really hard for us to admit that, both to ourselves, because we want to think we know what we're doing, right, and to patients. We want our patients to trust us and believe that they're going to get better. But I think the truth is we still have so much to learn, and so these treatments are available, but they're not necessarily evidence-based, and they're not necessarily going to help us. And I think slow medicine is something we can come back to, because what we do know is that even if we can't cure a disease, we can help people learn how to bear that disease and to function with that disease. And that's something we can do if we sit down with the patient and talk to them and work with them. And that works 100% of the time.
So I want to talk a little bit about the term slow medicine. You mentioned that you learned a little bit about the term in medical school, but it really has not been widespread in use and widespread understanding in our society what it means. There have actually been a couple books about it. Victoria Sweet and David McCullough have written great books titled Slow Medicine, talking exactly what you've been describing, Elena. So anyone might want to check that out. But the slow food movement gained a lot of traction for a couple of years. And, I wonder if there's an opportunity to get the term slow medicine out there so more lay consumers have a way to articulate what they are hoping to get out of their healthcare experience. Do you see that happening and see value in that?
Absolutely. I mean, I think if you ask a patient what they want from their provider, they're not going to say, like I said, I think most of my patients that come to the office, if I really ask them, I said, did you expect me to fix this for you today? After you've been to 10 doctors and 10 specialists about this over the last decade, I don't think patients expect that. I think what they really want from their doctor is a doctor that knows them, that listens to them, that they trust, that does what the hot term in the industry is shared decision making, right? Working with the patient to make a decision, helping them feel like they get options that they then get to choose based on what they think makes sense. So I think that patients, the more we put this word out there, this concept out there, and the more patients learn about it as a concept and demand it of their doctors, the more we're going to see doctors realizing, this is the way that this is what our patients want from us.
Well, I think so much of the doctor-patient relationship is a fit. I have patients in my practice who I really connect with. And then others, you meet and you can just tell the philosophy is a little different and they might find someone else who's a better fit. And I feel if we use the term slow medicine, that would be a term that people could help match people with someone who has a similar style. So my last question for you, Elena, is at a policy level, if we think the balance is too far in the fast medicine direction, what could we do to balance things out a little better?
So I think we need to incentivize hospital systems and individual clinicians to want to do slow medicine. Now, how do you do that? We need to change the way we compensate physicians for their time, and we need to change the pressures they feel on a day-to-day basis. So, for example, if I was relieved of the pressure of having to feel like I had to see a certain number of patients, I would be able to spend more time with each patient. So if I was, getting paid, regardless of how many patients I saw, that would make a difference. It would free up my time. We need to change the way that we are billing for office visits. So, for example, there's been a lot of talk, and there are some billing codes within both Medicare and Medicaid now that bill for collaboration of care, for sort of the things that you're doing outside the office. So, for example, I had a patient just this week. She has been trying to come see me to get her HIV medicines. She has not been able to do because she does not have transportation. So I had to spend probably a half hour on the phone talking to her insurance and the transportation company to get her transportation so she can get to her visits, right? This is how I'm going to make her healthier, is getting her here. And I don't get paid for any of that. And so we need to create, our insurance systems, our private insurance systems and our Medicaid systems need to compensate that time. And there's some codes for that are called, collaborative care codes and things like that. So that's starting to become a concept. But there are ways to incentivize this kind of care. And we're getting there, but we're not there yet. I think payment reform, and dare I say the controversial words, a single payer system, and things like that we can get into at a whole nother podcast.
Well, we do have a whole nother podcast on that. Steffie Woolhandler and David Himmelstein, who are probably the national leaders in single-payer national health insurance. We did an episode with them a couple months back, so check that out. And they do talk about this, how a single-payer system could help us shift in the right direction in terms of slow medicine and being more thoughtful and clinical decision-making. So I agree with all what you said about the payment reform. I am personally a fan of simplicity, and I think the simplest way to pay doctors is capitation rather than billing for every individual service, even if it is collaborative care and non-doing things. I think the simplest way is just to give a fixed payment for caring for a patient, and that way you have the ability to call on the phone and spend a little time longer with someone who needs it and less time with someone else. Well, Dr. Elena Hill, I so appreciate your joining today. You're doing great work in caring for a population that really needs it in the Bronx. If you found today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Search for Healthy Skeptic MD on YouTube. Pass it along to friends, family, and others who might be interested. And if you do have a chance, please do consider leaving a review. We'll pick it up again in a couple weeks. Thanks.